generic term. Who is making this treatment in general? Who's initially treating this patient? Nephrology. This is, all these nephrotic syndromes, all these nephritic syndromes, all need to be referred to nephrology. They might get them started on the drug and follow them through the course of their disease, but then subsequent to that, they're back on our service, right? Okay. So that's it. Remember, minimal change disease, kids, steroids, membranous nephropathy, adults, ACE are maybe steroids, right? Okay. Now, think about the title, dissect it. Focal segmental glomerulosclerosis. What does that mean? A focal area of a part of glomeruli are sclerotic. That's literally what it means, and that is exactly what it is. Renal overwork injury, okay? Primary is weird. Secondary is more commonly what you're going to see. So secondary to something else. That something else is often diabetes or hypertension. These, I just put two words together. That was all. This is hypertensive nephropathy and diabetic nephropathy. Okay? And we'll go through the mechanism when we get to, we got a couple slides down. But essentially, if you think about it, once this starts to develop, you have nephrons that are either partially functional or entirely non-functional because they're sclerotic, right? What does that do to the workload of the remaining nephron mass? It increases it, right? And then renal hyperperfusion or overwork injury, what does that lead to? More sclerosis, less functional nephron mass, and spinning and spinning and spinning and spinning down, right? So that is how diabetic nephropathy, hypertensive nephropathy work their way from stage 1 into end-stage renal disease. That's what we're trying to prevent with ACEs and ARBs and early identification and screening, okay? Let's see. So this is a good picture of it right here. That's GN, just a little piece of the nephron that is just scarred down and non-functional. The remaining glomerular mass works somewhat pretty inefficiently, if at all, and it's not too long before the remainder scleroses as well, and then it just works its way. This is the entirety of the kidney. Millions of these nephrons shutting down, and then eventually you're left with end-stage renal disease, okay? And so, you see this? Right? Because renal disease doesn't show up as renal disease. Renal disease shows up as either symptoms of something else or incidentally altogether. Again, it's just more of my central theme of just don't let this stuff walk away. Like this patient seems healthy, asymptomatic proteinuria, dipstick positive protein. Well, he was probably exercising earlier, no big deal. Yes, big deal, right? Potentially. Right? Told you. It's always the answer. Just like on Jeopardy back in the day. Say Mississippi River. It's always in there. All right? And then we only really use steroids for primary FSGN, which is, again, not nearly as common as secondary because it is a primary intrinsic renal disorder of the nephrons, more or less common than hypertension and diabetes. Right? Epidemiology usually, it's ubiquitous. Everybody has hypertension. Everybody has diabetes. Right? So it's everywhere. And that's the more likely reason why you're going to see it. Any questions about those nephrotic syndromes? Those are the primaries, even though FSGN is bucketed with the secondary, but it can be. But really what we talked about, minimal change disease and membranous nephropathy. Any questions about those? How you can put them together and just kind of separate them. Labs are going to be the same. One's a kid, one's an adult, basically. Okay? Secondary diseases, well, our old friend diabetes. Okay? And I just gave away the game about what develops with diabetic nephropathy. And we have talked about this in pieces and parts. Now this is just it together, right? We have diabetic patients. What really kills these patients' kidneys? The proteinuria and the poor glycemic control. Ultimately, if we can get this patient under glycemic control, we might even reduce the need for an ACE or an ARB, even though they're going to stay on it. But we might preclude them from needing an SGLT2 inhibitor, a GLP-1, like if we can get these patients to good glycemic control. And that's the rub, because type 2 diabetics are notoriously difficult, right? Until you saw their feet off and they're like, oh, okay, now I'll listen. Well, it's too late. You know what I mean? So unfortunately, you know, this is not just a problem with type 2. The type 2 diabetic is sort of the prototype that we think about, because they're usually poorer with glycemic control. Type 1 diabetics, you know, either they're going to take their insulin or they're going to die, so they're pretty good about it, you know. The problem is that same thing happens with type 1 diabetics. You know, their disease burden by duration is generally longer, right? We used to refer to type 2 diabetes as adult onset diabetes, right? Not so much necessarily, but if you have an inherit type 1 diabetes, you know, then their disease burden starts almost at birth and then progresses through. So their disease burden on their kidneys is much longer. They're likely to progress to end-stage renal disease almost even more so than type 2 diabetics who are well controlled, right? Just because of the duration of disease. So don't forget them is the ultimate point, right? We worry about their insulin, we worry about their glycemic control. They're usually in control because they're usually very, very good about it, but let's not forget their kidneys are still at risk, right? When we think about unhealthy prototypes, say, type 2 diabetic condition is really what we kind of come to mind. And you know what I mean? But don't forget type 1 diabetics are at the same risks of all these secondary diseases and sequelae, okay? Excuse me. So, this is the mechanism right here, and it's what I just spoke about. Essentially, it's glomerular overwork, and glycemic byproducts lead to that sclerosis over time, sclerosis, more, to break down. Then what happens is, as the nephrons start to sclerose down, the remaining nephrons have to work harder under a higher pressure, and so they become sclerotic, and then eventually that is the mechanism for the slide down towards end-stage renal disease, okay? Make sense? Generally, pathophysiology? Okay. And then again, if we don't catch it, right, this is what's going to happen. Dollar for dollar, side by side, higher degrees of albumin spillage are going to be higher risk of secondary outcomes and morbidity, mortality, okay? So we really are trying to get after their protein and find it early. So, you know, the microalbumin test, seemingly not a big deal, revelatory in the fact that we didn't have to wait any longer to either do a 24-hour urinalysis or wait for dipstick to be positive, right? And so you can see, like, this is a pretty urinary protein, right? As it gets worse and worse and worse, GFR, it just shoots down, and this patient goes from stage 1 to stage 4, and ultimately, you know, this progression happens regardless. What we can do is lengthen the timeline, right? By making sure they're under glycemic control, making sure their protein is staying where it belongs. So don't figure out, I mean, this is a visual representation. You don't have to get into the weeds down here of the words. It's just the progression of diabetes, which you already know because you learned it in endocrinology. On a kidney, you know, from a kidney perspective, what we're trying to do is lengthen renal health and life, okay? Because then, what else does that affect? If we keep the kidneys healthy, what else is going to stay relatively healthy? The heart, yeah, and then subsequently the liver, and then subsequently the patient who has those things inside them is going to live longer, which is good. Right? Write that down. Right? So diffuse glomerulosclerosis. Okay? Same. We talked about this. Right? This is everything we've been talking about. I mean, chemo, you know, these little nodules. Who cares? It doesn't matter. That's a pathognomonic finding. That's one of the, you know, I guess I learned about lots of pathognomonic findings that are never actually there. This is one of them. Okay, so there's no reason to remember it. All right. What does this patient have? A diabetic history and poorly functioning kidneys. Well, you got it. There it is. Okay, you put it together. Right? Regardless of what the electron microscope says. Right? Easy peasy. If we can get them to be in good glycemic control, then we will affect change, right? Patient education. That's the hardest thing, lifestyle. You know the hardest treatment? Yeah, everybody, we always have these treatments, right? Treatment. And at the bottom it always says therapeutic lifestyle changes, right? You know which one of all the things on that list is the hardest thing to get patients to do? Therapeutic lifestyle changes. Smokers don't want to stop smoking, drinkers don't want to stop drinking, people who don't exercise don't want to start exercising, and people who do all of those things definitely don't want to do shit, right? And if we could get them to do it, it would be so much easier. Because then all the medications above therapeutic lifestyle change would become less and less and less necessary. So patient education is going to be one of the hardest things for you to do when you get out there. And sometimes you have to be really, really frank. You know, I've looked at patients and said, do you want to die? Do you want to see your grandkids live? You know, do you want to carry your grandkids? Like, do you need, you know, I want to get my, you know, master blaster raised. Like, do you want to walk when you're 60? You know, do you want to be able to pick up your grandkids? Or do you want to have the thing in a shadow box? Like, come on, think about it. You know what I mean? So strict glycemic control. SGLT2Is, we'll talk about those quite a bit. Well, I won't say quite a bit, but enough in chronic kidney disease. GLP-1s, obviously, you know, they do everything, right? They do everything now, right? You could just go to, I think you can go to HEB and get Ozempic now, or some formulation of it. You can't, I'm just kidding. But a lot of people are on Ozempic who don't really need to be on Ozempic, right? This is why diabetics are having a hard time getting it. I don't know, I'm not getting on a soapbox, whatever. Anyway, blood pressure control, ACE or ARB, equally as important. And then lipid management, right? Kidney health, but this is just, what is this? This is diabetes management. You guys already know this stuff, all right? Hepatitis C associated kidney disease, less so of a burden now because of our super fancy hepatitis C drugs, right? So the disease burden, you know, hepatitis C, when I was in school, was, you know, essentially a sentence that involved either liver transplant or dying. So not two great options. Right now it's not so. We essentially clear them, right? So the burden of hepatitis C kidney disease is less so. If you do have a hepatitis C patient, just the takeaway of all of this, okay? Don't spend too much time. The takeaway is just pay attention to their kidneys as well. All right. What you guys learned in GI, I hope, about the hepatitis C meds that can literally, you know, viral clearance, essentially heal the patient. Yeah? Okay. Lupus. All right. You will talk about lupus in rheumatology. We will talk about lupus nephritis right now, briefly. Okay? Here's the takeaway from lupus nephritis. If the patient has lupus, keep an eye on their kidneys, make sure they get a referral. If you're following a lupus patient, make sure you give them a referral to nephrology. That's part of like a standard annual health visit. Or more often, as necessary, if their kidneys start to go south. And keep an eye on them. What do you think the patient needs to be on if they're a lupus patient to keep their renal health intact? Oh, ACE or ARB. You got it. George Costanza, in case anybody doesn't know who that is, right? Any Seinfeld fans, hopefully. Right. So lupus nephritis, right? Do you guys need to know this? No. So, next. HIV-associated nephropathy. HIVAN, if you want to be cool and say it. That's what you'll see it potentially in the literature. So, just understand that the treatment for HIVAN is antiretroviral therapy or PrEP to not have the spread of HIV depending on your patient population, right? Either way, just understand that HIV and the drugs do take a toll on the kidneys, so ACE or ARB, okay? And if you don't think you'll see HIV in the military, you are incorrect, okay? Renal amyloidosis. Anybody know what amyloid is? Besides what it says up there? Did anybody know before it said abnormally folded protein? Yes, good for you. It is. Amyloid. Amyloid is a protein deposition disease. It occurs systemically. The kidneys are just one of many sites where it deposits. An amyloid patient doesn't do well. This is generally a progression to multiple organ failure. So ultimately all we're really trying to do is identify early. But the really reason I really put this on here is this is just another one of those things where all you think you might see early on is some unexplained proteinuria. And you might be the one that diagnoses renal amyloidosis or amyloidosis in general before the patient has any other overt symptoms, okay? All right, good. This is a chart for you. I know you can't see it. Maybe you can see it when you're closer, but it puts them all together. This is a chart I made that just contrasts and compares nephritic and nephrotic syndrome. So if we, 2 words for nephritic syndrome, blood and hypertension, right? CAS, red cell CAS, right? Nephrotic syndrome, fat and protein and swelling, right? You guys remember that? And then this is just sort of what happened, right? So change this GFR on the low range of normal rather than normal low. Both of them are still intrinsic renal disease. That's the only real thing on here that should be adjusted. But you get it side by side, spot the differences. Blood goes one way, fat goes, protein goes the other. Okay? Questions about nephritic, nephrotic? Good. Right, this next one's going to go fast, and we'll do one more because this is an easy one to get through, and then we'll get you guys out of here, okay? Because this next one, this where we're at now, is sort of at the end of acute disorder, and we're moving into more chronic renal disease. And so these next few slides, especially this one, is just a, sort of a prelude to the end. All right. This, in case you're wondering, like, what I want to do through, this is like 20 slides, maybe 12 of which have any real material on them. It's very high points. I'll tell you exactly where you need to be on this one, because ultimately, this is just a bucket of chronic renal diseases, and they present as such. The only thing that makes these ones that I point out here unique is that they have specific risk factors. So specific things, exposures, or inherent abnormalities that you can help identify and prevent in your patient population, if that makes sense, and hopefully it will in just a second. So tubulointerstitial diseases, we've already talked about tubular and interstitial diseases in a acute setting, right? Tubular necrosis, interstitial nephritis. Just talking about the areas of the kidney, the areas of the nephron, where these diseases exert their pathology. So nothing specific, okay? And we talked about acute versus chronic. Like acute interstitial nephritis has those acute presentations, but it's still not severe rash, arthralgias, acute decline in GFR, right? Chronic interstitial disease. This is something patients do to themselves over time. And again, chronic renal disease is slow and insidious. Kidney disorders, inherently, even chronic ones, somebody with even a markedly reduced GFR might not overtly present with anything, even dark urine, right? And so again, risk factors are inherent. For us, what do? Identify that patient is at risk and see if we can prevent the onset of these disorders, okay? Generalized symptoms, polyuria or more likely frequency, okay? So they're going to the bathroom all the time, much more often than necessary. Chronic tubular diseases, insensitivity to ADH, remember what that does? Conserves our water. So if we're not conserving our water because our kidneys are not being able to react to the ADH that is present, then we have a dilute urine, okay? Which leads to a relative hypovolemia, which leads to a turn on of RAS, which then leads to salt wasting and potentially hypokalemia, right? So, lab findings generally. Does anything on this list, I know we haven't talked about isostenuria on this list yet, but does anything on this list not make sense in the picture of a kidney who is now chronically ill and not functioning correctly? Any of it? I mean, seriously, if you just look at the list, does anything stand out? Right? We talked increased BUN and creatinine, reduced GFR, signs of intrinsic renal disease, hyperkalemia, because what I just said, metabolic acidosis, because of the uremia, right? One of the mud piles in Goldmark. Urinalysis, hematuria, pyuria, Broad and waxy casts, you remember those as evidence of chronic renal disease, and stasis in the tubules. High urinary sodium, because why? Kidneys are broke, right? Glycosuria, phosphaturia, remember phosphate, I didn't spend a whole lot of time on it, but I did say that's what's going to come into play when we have chronic renal disease. The most likely cause of phosphate deficiencies or phosphate alterations is chronic renal disease. And then proteinuria, right? Everything is wrong. All the stuff we're supposed to be keeping, we're losing. All the stuff we're supposed to be losing, we're keeping. This is the complete inverse of what kidneys are supposed to be doing. That's chronic renal disease in a nutshell, okay? But here's what isostenuria, basically what that is kidney tubules, renal tubules that now are insensitive to ADH and also unable to concentrate urine in any fashion. So basically, the specific gravity of the plasma is going to be equal to the specific gravity of the urine. So how would you know this? You would see this as a pattern, right? You have somebody with chronic kidney disease, you notice that their specific gravity of the urine never changes, regardless of their fluids, electrolytes, or state of volemia, okay? Just a word to define so that you guys understand what it means. Treatment is treat the underlying disorder. Let me show, I'm going to just skip to the end because we're going to talk about treatment in the individual ones. Here's for all my Boston fans, OVA, right? OVAH, it's not an acronym, I made it up because it makes me laugh, because these people's lives will soon be over, right? Right, yep. Obstructive uropathy, what do we talk about? What is that? Post-renal renal disease, that has now become chronic renal disease, okay? Obstructive uropathy, what does it mean? Obstruction. Think of things that can, Stone, yeah, stone, prostate, neoplasm, stricture, whatever. Exactly, that's exactly what, some kind of obstruction. It's a post-renal AKI, but now this is post-renal CKD, chronic kidney disease. So it's gone on too long. You see what I'm saying? Remember I said there, it meets in the middle if it's prolonged? This is now, it has become intrinsic renal disease. Most likely patient you're going to see with this one? Prostate patient. Okay? Prostate patient. Slow, insidious growth. Over time, continues to grow, space narrows, the ability to remove the urine becomes less and less and less, and then obstructive uropathy develops. Okay? And we will talk in the next block about how we prevent that from happening. Vesical ureteral reflux. We have also talked about that. I don't know if you remember, but we talked about that when we got a avoiding cystourethrogram, right? So that is a patient, usually a kid, who has recurrent urinary tract infections, and the reason for that is vesical ureteral, right? The part where the ureter meets the bladder, there's a physiologic sphincter. If that is inefficient or poorly formed, what happens? Urine refluxes back and chronically goes back towards the kidney, causes a hydroureter and a hydronephrosis. And what do we know about hydronephrosis? It obliterates the renal parenchyma over a course of time. Okay? That's a chronic tubular interstitial disease. Analgesics, in addition to be able to do real damage to your acid-base balance over the course of time, analgesics can really wreck your kidneys. I told you already, the nephrologists, use the euphemism that, one of the things that buys boats in summer houses for nephrologists are NSAIDs. Right? Heavy metals, lead. Anybody here worked in shoot houses and stuff like that inside? Where you have lead, you have your lead levels checked regularly? Or anybody else? So it's common, more common than you'd think. Like we already associate, lead and poisoning with people who live in a house that was built in 1978 and people eating paint chips, but that's not really the case. It is the case sometimes, people who work in shoot houses sometimes do eat paint chips, but it is more common than you think, and it's something that we have to be cognizant of so that we can know when and who to screen and what to do if that screening becomes positive, meaning that lead-associated nephropathy is starting to develop. Okay, so that is all of that. This is that in words on the slide. Okay, so obstructive uropathy. What do you think the treatment for obstructive uropathy is? Remove the obstruction. Right? Whatever the cause. Okay? Clinical findings of obstructive uropathy, similar to the clinical findings. So, if you remember the post-renal AKI slide, right? It starts as the same as pre-renal, and then it moves its way into a post-renal picture, into an intrinsic renal, from a post-renal picture into an intrinsic renal picture. right? So labs, we probably understand. The BUN and creatinine both going up, GFR is going down. We're wasting sodium. We're not necessarily concentrating our urine, right? Everything signs of intrinsic renal disease. Okay? That's what azotemia is. Hypertension likely, right? Polyuria or oliguria, right? Depending on if the patient's. What would make the patient most likely oliguric in a post-renal obstructive process? Huh? What'd you say? No, just in, not, yes, a prostate is a problem, but like specifically, what do you think? A total obstruction, exactly. Complete obstruction would most likely be an anuric presentation. And that is more common than you might think. And then again, you get that swelling in the bladder, right? Yeah. And then everything on here makes sense? Only thing that might not would be the radiographs, but again, what are we doing? We're just using our various studies to find where the obstruction is and why. Okay? And that'll be, this will put much more of a button on in the next block, okay, of a specific radiographs to look for obstructions. But all these labs hopefully should make sense to you. One that stands out here, bacteria, why? Stasis, right? What did I say about static fluid? It grows stuff. Exactly, okay? There's a good picture for you from Netherfield. You guys are familiar with the hydronephrosis. And again, same thing is going to happen with vesicular reflux over the course of time. And just as the usable renal mass becomes more and more obliterated, now we are going into severe obstructive uropathy renal disease, all right? A couple more slides in this slide deck and you guys are off to break. Don't worry about it. All right, we've already talked about everything, right? So vesicular reflux, told you what it was. Typical, prototypical patient is going to be, like I said, that child that has frequent urinary tract infections. That should be an indication for referral to peds urology, all right? To see if they need a VCUG, right? Voiding, so VCUG, voiding cystourethropy. And what that is they instill dye in the patient. Patient voids under fluoroscopy, and we're looking for that dye to go north where it doesn't belong. Does that make sense? So it's just a full bladder, has a dye sits in the bladder, patient pees under an x-ray, live stream. Dye goes this way, no good, okay? Grades of it, but that doesn't matter for you at all, but there are different grades of it. But ultimately, the reason for the infection is because we're chronically not emptying the bladder fully. We're getting that stasis and that expansion in the ureters and then up ultimately into the kidney. So it's the first sign of what could potentially be a serious renal disease for this kid if we don't fix it, which is easily fixed, all right? Analgesic nephropathy, much less common, okay? Much less common than it used to be because some of the more, some of the aspirin, or excuse me, Tylenol analogs that are most likely to cause this are not available anymore. But ultimately, you guys remember the NSAID renal blood flow thing, right? The NSAIDs work on the prostaglandins. And the prostaglandins are what allow the afferent arteriole to open and close, right? So prostaglandins actually cause the afferent arteriole to open up. So if we have an NSAID that blocks those prostaglandins, then the afferent arteriole, the end pipe, is chronically small, meaning the flow of blood into the nephron is chronically obstructed or lessened, if you will. Over the course of years and years and years and years of that, patient can produce a relative hypovolemic state in the nephron. Like you can see a relative sort of hypovolemia and institute a kidney disease. Even though acetaminophen is cleared by the liver, acetaminophen combo products can have a problem because, you know, acetaminophen, like Excedrin migraine, right? Aspirin and acetaminophen. So in the presence of salicylates, acetaminophen is reduced to glutathione, but glutathione levels are affected, and so even in the acetaminophen aspect of the combo product can exert a oxidative stress on the kidney and cause the same analgesic nephropathy. What is the takeaway of everything I just said? Be careful with your patients who have chronic kidney disease. Be careful of the patients who think that if 1 is good, 4 is better, right? 800 milligram motion 3 times a day works, well then 800 milligram motion 6 times a day should work even better, right? You'd be surprised the number of patients who do that. And also, over the counter, all this shit is so available over the counter. Understand what your patients are already taking, okay? And just be careful. And if they're taking chronically, you're talking about patients. You know who's a big culprit for this back in the day? Migraine patients. Headache patients, chronically taking tons and tons of naproxen and Tylenol and aspirin to try to kill that headache. Not so much anymore because we have way better drugs, but just be careful of patients who have been taking meds for a long time. The other one that you might think or you might see is a self-diagnosed arthritis patient who never comes to the doctor, right? Never goes to see a provider. So they just buy tons of over-the-counter NSAIDs from Costco, you know, that come in like horse troughs, right? And they take 1 a month, so 1 trough, not 1 pill. So, again, if I see clinical manifestations and labs, does anything on here not make sense? It's the same labs, it's the same shit, there's nothing special about this one. Okay? So, okay? Analgesic nephropathy, small echogenic kidneys, signs of renal disease. Like you guys remember that, signs of renal disease, shrunken kidneys. Treatment, if it hurts when I do that, stop doing that. And send them to nephrology. You guys good? We're almost there. We have like 2 slides. You guys are gonna be fine. You're gonna be fine. Heavy metals, right? Lead. I don't know if anybody who works in cadmium mine, but if you do, keep an eye on them. All right. Mercury. If anybody you know eats thermometers, tell them to stop. Lead is the real culprit here. Okay, lead. We will have patients who have exposure to lead, routine exposure to lead. Like I said, especially if you're shooting indoors. Okay, you have to be careful of those patients, and so you have to check their lead levels, right? Sailors, depending on their work, like their work environment, may be exposed to greater levels of lead. So you have to be careful of what they do and know, through occupational health, that you're going to be monitoring their lead levels and when to appropriately stop, right? We're not really waiting for lead nephropathy to start, right? Because then it's too late. The lead is already accumulated, and not just in their kidneys. We're just talking about the kidneys because it's kidney class. So understand, you don't need to memorize these labs. Like, you don't need to memorize this shit. This is stuff that you need to look up and understand. Occupational health, look on up to date. What should I be looking at? And basically, if you see the bottom line takeaways, if you have a patient who has an exposure of lead nephropathy and their leg starts to go up, take them off whatever they're doing, and then see what you're supposed to do, right? Because if they're already starting to bump their labs, they've already accumulated a pretty significant amount of lead, all right? So there's 2 different things. Lead-related nephrotoxicity, that's what we're looking for. We're not looking for lead nephropathy. Lead nephropathy is a chronic disease. That means that we haven't done our job proactively enough. We are looking for this. Lead-related nephrotoxicity, meaning that their labs are starting to go off. So what do we think of? Like, how do you put this story together? Risk factors, reduction in GFR, and lead. Okay? That's it. All right? Just understand the patients that you need to check their lead levels and check their lead levels. And we're not going to remember those. We're going to look them up and be like, that's too much. If it says H, that's bad. Right? If the Genesis readout comes out, you're like, it's in bold and red. Lead, something to something, frowny face. Stop them from doing whatever they're doing and readjust, okay? And then enough. Take a break, we'll come back, we'll knock one more out, and then we'll be good, okay?